It's interesting. I started my academic career here at Carr Hall in undergrad. And then when I was doing my pediatric training, I was up in London. And guess who my mentor was? Dr. Barry deVeber. So it is a special place to be here. I'm always humbled by an invitation to speak about women's health after abortion, for I am, despite what Barry says, a very ordinary family doctor. The first time I was called to speak about abortion or on the topic of abortion was about 30 years ago last month. It had been a very busy summer for me. I had completed my undergraduate medical studies in the end of May, beginning of June, and at that time we sat about 10 days of oral and written exams. Following that, my husband and I moved out of our family homes, or at least we moved our beds and furniture out of our family homes and into this dump of an upstairs apartment, and spent the week after we finished our exams stripping wallpaper, stripping floors, waxing floors, because there was no such thing as urethane for floors in those days, and painting, and then concluded the week by getting married. We then went on our honeymoon, came back and graduated and started our internship, and did all of that within about 2 weeks. We started an internship before Pero had decided that it wasn't appropriate to cover 1 out of 2 on-calls, so we were immediately working down at St. Michael's Hospital, doing 1 and 2, 1 and 3 on-calls, which meant we would work 36 to 48 hours straight and then have 12 hours off to sleep and go back and do it again. I was exhausted, and 6 weeks later, as I was sort of trying to deal with my fatigue and this ongoing problem which I'd had with nausea for the last number of weeks, I was in the back of a limousine going to my best friend's wedding as her bridesmaid, and I kept on doing this. 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. And after I'd done this for about 3 or 4 times, Mab looked over at me and says, "Debbie, what is your problem? We know you can count to 6. I said, "I'm pregnant." Pandemonium burst out in the limousine. All of my friends were in the medical field, and all of them asked the same question. "How did you do that?" You would think that medical people would know how one did that. If I had $1 for every time somebody asked me, "How did you do that?" when they found out that I had become pregnant, I would have been able to pay off my rather large student loans before the end of that summer. However, they weren't paying me for that question. And at that point, I was just trying to cope with this idea that I was pregnant. Then all of this fuss and commotion amongst the family and my friends didn't prepare me, though, for the morning that I stepped onto the elevator in the Queen Street entrance of St. Michael's Hospital. At that time, the Queen Street entrance was the busiest entrance of St. Mike's. And in the morning, the elevators were all full, like chock-a-block full. If there are no seats back there, there are seats up here, and I don't eat the people who sit in the front seats, okay? So I stepped into the elevator, and it was, as usual, on a Monday morning, full of people, and I noticed one of my internship colleagues was on the elevator as well, and I said a cheerful good morning to her, and she turned on me and said, "How could you do it?" I went, "Oh, good, this question again. Okay, how could you get pregnant?" But she didn't wait for the explanation of how one gets pregnant. And she went on and ranted. How could you get pregnant? How could you get pregnant and foist your call on the rest of us? How could you be so selfish, so irresponsible, so silly, and so stupid to get pregnant at the beginning of your internship? You really don't expect the rest of us to cover your call, do you? I hear that you've already taken off half a day from the renal clinic. You are going to get an abortion, aren't you? Remember, this was at St. Michael's Hospital, the Catholic hospital in Toronto, and the elevator was full of people. I was dumbfounded. Yeah, I did feel stupid, actually, getting pregnant, you know, the beginning of an internship, and yes, I was confused. And I was a little bit worried because we didn't have any money. We were living in this dump, and I was beginning my internship, and there was a lot of call to cover. But I knew I was working in a Catholic hospital. I was married. I was married to a wonderful guy who came from a Catholic family, and I had a wonderful family, he had a wonderful family. I had lots of friends, and I already had an undergraduate degree and a professional degree under my belt. So, was I really stupid? There was a major disconnect here. She was telling me I should get an abortion because I was stupid. I was shaken from my daze and from my wondering by her strident voice demanding, well, are you going to get an abortion? Or are you going to really continue to be stupid? So for the first time 30 years ago, I found my voice and I quietly spoke up on the topic of abortion. And I said to her and everybody else standing in the elevator, I'm having my baby in March, I think. Things have not changed very much in the last 30 years, and society's reaction to women who find themselves with unplanned pregnancies is no different. Unplanned pregnancies are treated as disasters, not gifts for the women who become pregnant. Inconveniences, inconvenient situations, which women get themselves in because they're stupid, foolish, silly, or selfish. Just as I was labeled because I wanted to continue my pregnancy and have my baby. For society's views on unplanned babies are that they are expendable. And society considers abortion to be the right way to treat the problem of unplanned pregnancies. As abortion has become the banner fight for women's rights groups, the dignity and rights of both women and the unborn infant to health, autonomy, and self-determination has been trampled in the mud of political wrangling and economic expediency. Political agendas and financial considerations have prevented the dissemination of validated research results that show that induced abortions are not right for not only the baby, but for the mother. And indeed, induced abortions have two victims, the baby and the mother. Why? Because of the many complications and serious side effects that abortions have on women's health. In medical lingo, when a procedure or a medical intervention causes a problem, which is either negative or deleterious, we call it a complication. And we divide complications into a couple of groups, immediate and long-term, and we divide them on the basis of how frequent they are and how severe they are. And to put the context of complications following abortions into perspective, let's look at some of the statistics in Ontario. The average outpatient surgery done under a general anesthetic has a complication rate of about 1%. The orthopods actually get the Silver Needle Award because their complication rate for arthroscopes is 0.15%. You must remember that all of these statistics are for surgery which are done under general anesthetics, and when the complications of which include that 1% are looked at, almost all of them relate to the anesthetic. Very few of them relate to the actual procedure. So what do we know about the complication rate for abortion, induced abortions. Well, the Royal College of Obstetrics and Gynecologists in Britain, in their training manual for physicians, lists the short-term complication rate of surgical abortions at 11%. This is a 10-fold increase over the general surgical complication rate with general anesthetics. That's a full anesthetic when you're put to sleep. However, induced abortions are not done under general anesthetic. They're done with a local. There are no anesthetic complications for induced abortions. So what compromises this 11% complication rate? Translating the numbers into homegrown statistics, we can break it down. Because in 2001, when the government was in a bit of a crunch financially, what they wanted to do in the healthcare system was move outpatient surgery from an in-hospital setting into a clinical setting in the general, a clinical setting outside of hospitals, because they thought that that would drastically reduce the cost of the procedures. So they asked the College of Physicians and Surgeons to take a look at the question and answer for them, would the complication rate rise if they moved simple, uncomplicated day surgery cases out into the community? So the College of Physicians and Surgeons, who had access to all the data, decided to look at the most common outpatient surgical procedure, which was done in clinics at the time, which happened to be induced abortions. And they found out that following induced abortions done in the clinic setting, there was a 4-fold increase in admissions to hospital for medical problems, a 5-fold increase in admission to hospitals, overnight admission to hospitals for surgical complications, and a 6-fold increase in admission to psychiatric beds. At that time, there were fewer psychiatric beds available than there are now. Currently, if I want to get a patient admitted to a psychiatric bed, the patient has to qualify under 2 restrictions. They either have to be at risk to themselves or at risk to the others. So either they have to be suicidal or homicidal. That is the only way you can get a psychiatric bed for a patient currently. Last year, I had a child who had severe anorexia nervosa. She had lost over 30% of her body weight, and she weighed 87 pounds, and she was 5'6". I phoned everywhere in Ontario to get her a psychiatric bed. I couldn't. I talked to the head of the anorexia nervosa department, clinic at Sick Kids. I said, what am I supposed to do with her? She said, I really don't know, because we don't have a bed available until February. This was October. And she will be dead by then. That's how difficult it is to get a psychiatric bed. But there was a 6-fold increase in admission to psychiatric beds in the 3 months following induced abortions in 2001 in Ontario. That meant those women were either suicidal or homicidal. So what accounts for the 4- and 5-fold increases in admission to hospital for medical and surgical problems in the weeks following an induced abortion? Almost all of these are related to infection, okay? And the medical ones are all infection. The surgical ones are infection related to combined with bleeding. Last week, I just got back from Africa, and I was doing an on-call clinic, and one of my patients came in to see me, and she was the grandmother of a child which I had delivered about 17 years ago. And so I asked Grandma what the problem was, and she needed a refill of her blood pressure medications. I said, fine. But Grandma kept on sitting there. And I said, "Oh, I'm running a half an hour late." Actually, it was probably an hour late. "It's an on-call office. Is there anything else I can do for you?" And she looked at me and she said, "Yeah, Dr. Debbie, you have to do something about Kate." I knew Kate was her granddaughter, and I said, "What do I have to do about Kate?" And she said, "Well, Kate's not well." And I said, "Oh, what's the problem with Kate?" "Well, she's bleeding." I said, "You mean she got vag bleeding?" "Yeah." "She's got pain." I said, "Oh." I said, "Well, has she seen anybody?" She said, "Well, yeah, she was in the women's clinic the other day in downtown Georgetown, and she saw the doctor there. And the doctor gave her some nonsteroidal anti-inflammatories and told her she was having a particularly nasty period." I said, "Probably she is. I'm sure the doctor did a good job treating her. She's a very good doctor, and I don't think you should worry about it." And Kate's grandmother said, "Well, I am worried." So I put that in the back of my brain as I ushered her out of the office. And I live in a small town, and I work in a small town. And wouldn't you know it, but later that same morning, Kate's best friend was in to see me. Now, Kate's best friend isn't one of my patients. She belongs to one of the other docs in the clinic, and she had come in because she had a sore throat. So I saw the sore throat, treated the sore throat, and again, she sat there. Ooh, this was getting to be a bit repetition. Again, I looked at my watch. Again, I realized I was running late. And again, I said, "Yes." And she said, "It's about Kate." And I thought back to the grandmother, and I said, "What about Kate?" And she said, "Kate's really sick." I said, "Well, you know, it's really difficult for me because I'm not supposed to discuss my patients with other patients. It's called confidentiality." I had said the same thing to the grandmother in the morning, and it hadn't really cut mustard with her. And believe me, it didn't do anything for the way Kate's friend was feeling. She said, "Dr. Zeni, I really can't believe that you don't care." And I went, it's not that I don't care. It's just that I really can't do anything for Kate. She hasn't come in to see me, and she's already seen a doctor, and I'm sure she's fine." She said, "But you don't understand. Kate had an abortion last week." I went, "Oh." Kate had an abortion, she had lower abdominal pain, she was bleeding, and her grandmother was worried about her because she looked poorly. Actually, what her grandmother had said, she looked peely-wally. And if any of you are Scottish, you know that that means they look really poorly. And so I said, "Okay, so much for patient confidentiality." And I phoned up Kate. I arranged for her to come into the emergency department and did some blood work, took a look at her, and sure enough, she had lower abdominal pain. She was running a low-grade temp. She looked awful. She was really pale, diaphoretic. Her blood pressure was in her boots. And when we did her hemoglobin, instead of being 14 or 140, it was 70. So she had dropped her hemoglobin by almost half. We did an ultrasound to see what the problem might be, and there were retained products in the uterus. So the abortion that she'd had the previous week had been incomplete, and the abortionist had failed to take all the placental tissue out of the uterus and had left it there, and at the same time, infection had been introduced during the time of the abortion, and the bacteria had taken up housekeeping in these little bits of leftover placenta which were still stuck to the wall, inside wall of the uterus. She needed a surgical D&C, so we took her to the OR after hanging 2 units of blood and giving her copious amounts of antibiotics because she had, in addition to these retained products, both an endometritis and what we call pelvic inflammatory disease. Later that day, I was called back into Emerge to see another patient, and I decided I'd pop down to the floor to see Kate. When I popped into the room, her mother was sitting there with her, and I went, "Oops, I think I'm going back to the Emerge." I was really a little bit too chicken to face the mother and the daughter. I had no idea whether or not Kate had told her mother exactly what had transpired. But unfortunately, the mother saw me out of the corner of her eye and asked me to come in. And she said, I really want to know what's going on here. Why was Kate so sick? And I looked at Kate and I said, Kate's old enough now to be making her own decisions about her medical care. And I need to respect the fact that her care is a confidential issue. And I'm not really allowed to talk to you about what's going on. Kate was 17 years old. And this is true. The mother was furious. I said, you know what? Why don't you just step out in the hall for a bit and let me chat with Kate for a moment? And I asked Kate, did you tell your mom about the abortion? And she looked at me and she said, no, I can't. I said, why not? She said, she'll kill me. And I went, Kate, you almost died. You were just hemorrhaging. You've had 2 units of blood and you got piles of antibiotic going into you. I don't think you should worry about your mom killing you, but I do think you should tell her. She said, I'm just far too ashamed of what I did to tell my mother. I said, you know what? Your mom loves you. You need to tell her. Because what I know and what Kate didn't know is that it was going to be her mother's love and the love of her friends which was going to get her through this experience of having an induced abortion. It was her mother's love and the love and care of her friends and family which was going to allow her to heal. Yes, we'd done the surgical bit, we provided the antibiotics, but the healing that Kate would need in the next few weeks and few months would come from her parents and from her friends and from her family. This problem that Kate had of little bits of tissue being left behind occurs in about 5 to 6% of all surgical abortions in Ontario. And it's probably higher in some of the other countries where they don't have quite the same clinical skills and the same access to care that we have. The infection rate runs around 6% following abortions. And it is this infection rate which ends up causing the most severe of the long-term complications that I would like to talk about. Because when we put things all together, it's actually the long-term complications of abortion which are the most serious ones and make the short-term complications, which I've just talked about, pale in comparison. Why do girls get infected after they've had induced abortions? One of the things which happens is that you're entering into a sterile field when they do the suction D&C. You enter into a sterile field, which is the inside of the uterus, through what we call a contaminated field, which is the vagina. Because the vagina of any woman harbors ordinary, everyday bacteria. Sometimes the bacteria which are in the vagina are the same bacteria which are actually in the feces. And we all know that in our stool, there's lots and lots and lots of bacteria. That's why we tell kids that they need to wash their hands after they go to the bathroom. That's why we make sure that food handlers use proper hygiene after they go to the bathroom, because there's lots of bacteria in stool. And sometimes this gets into a woman's vagina. How else does bacteria get into a woman's vagina? Well, through sexual intercourse with a male who also has a sexually transmitted disease. The most common sexually transmitted disease in Ontario is chlamydia, and it is very common. In men, it causes symptoms of painful urination and a little bit of discharge. In women, most cases of chlamydia go undiagnosed and unnoticed because it's a quiescent thing. So prior to having an abortion, most women are given a prescription for antibiotic, which will reduce the amount of bacteria in their vagina. The problem is that a lot of the women don't take the antibiotic. Why not? Well, let's just do a little bit of a brief survey here. How many of you in the room have received an antibiotic for a strep throat or a urinary tract infection in the last year? That's all? Come on, put up your hands. Higher, 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 higher. Okay, how many of that group completed and finished every last pill? About half of you. And you can afford to buy the medication. So you actually bought it. You know, I'm not that much different. I just spent 3.5 weeks in Africa, sub-Saharan Africa, where they have falciparum malaria, which is really a serious form of malaria. So I took my meds before I went over there. I took my meds the whole time I was over there, and I was supposed to take my Malarone every day after I got back for a week. Guess what? There's 3 tablets of Malarone still sitting in my drawer at home. I forgot to take them. I got busy. And these girls are the same way. If they can afford to buy them, and you must remember that the majority of abortions are done on women between the ages of 16 and 25 in Canada, most of these girls do not have a form of income because a lot of them are at college or at university, or if they are working, they're working in usually food services or something like that without a high income. So they don't have a lot of money and they don't have benefits. So they can't afford the antibiotics in the first place. Even if they pick them up, the antibiotics often cause upset stomachs, grumbly tummies, and diarrhea. So after they've taken the first couple of tablets, they stop because they don't want to be put up with these sort of symptoms, and besides, they're not sick. When you have a sore throat and somebody says you got strep throat and gives you an antibiotic, you want to take the antibiotic because your throat hurts. But when you're not sick and somebody tells you need to take an antibiotic and you're between the ages 16 and 25 and you're invincible, you don't take the antibiotic. In the best case scenario, if women take the full dose of antibiotic, the infection rate following abortions is 8%. The average infection rate runs around 24%. Most of these don't get picked up. As I said, 6% of them show up and end up needing admission to hospital. The rest of them usually show up, just like Kate did, in the local women's clinic with a complaint of bleeding and pain. Some of them get antibiotics. Some of them finish their antibiotics. Most of them don't. And so they go on and have a chronic low-grade infection, usually caused by chlamydia, in their pelvis. This causes scarring and causes collections of pus down in their pelvic area. So what? Well, scarring and pus causes pain. So women with PID end up with chronic pain. And scarring and pus interferes with the action of the fallopian tube. So what happens when conception occurs, when a woman does go to get pregnant after they've had PID, is that what sometimes happens is that the egg gets fertilized, but the transport of the egg down the fallopian tube is stopped by the scar tissue. And so the fertilized egg actually gets lodged in the fallopian tube, and it's there that implantation occurs, the placenta starts to grow and erode into the very thin membrane of the fallopian tube. This can go on for a matter of weeks until actually the placenta erodes right through the fallopian tube and the woman starts to hemorrhage. If it's caught early and it's diagnosed early, ectopic pregnancies can be treated with methotrexate. And basically the methotrexate kills the conceptus if it hasn't died already, and it's expelled out of the far end of the tube and empties into the pelvic cavity. Of course, in that sort of scenario, the next time the woman gets pregnant, she still runs an equivalent risk of an ectopic pregnancy. If it's not caught early, it's another trip to the OR. And we know that ectopic pregnancies are a serious problem. In fact, they're one of those, what we call surgical emergencies, because they're life-threatening. And indeed, 7% of the women who die in Canada every year from complications of pregnancy actually die from ectopic pregnancies. So, are there any other problems with this issue of infection? Yeah, another problem is just the fact that the women end up with subfertility. So with ectopic, she can actually get pregnant, and the conceptus is lodged in the fallopian tube and it can't grow. But in other ways, the tubes are so clamped down that the sperm can't even get through to the egg, because fertilization takes place in the fallopian tube. So these women find themselves unable to get pregnant. In the average infertility clinic, a third of the women who present for infertility are there because they've had PID. And out of that group of women who have PID, over 50% of them had their episode of PID following an abortion. So we're talking somewhere around at least a sixth of the women presenting in the clinic directly attributable to infection following induced abortions. What does this mean? Well, a few years ago, I had one of my patients come into the office, and I knew this lass really well. She went to our church. I was friends with her parents. Her parents have now moved down to the States. She settled down and she got married, and she wanted to start a family. And so when she bounced into the office, we exchanged family news. I told her about how our boys were doing. And she told me about how her parents were doing and how her sisters and brothers were doing. And then I said, well, why are you here? And she got very quiet. And she looked really upset. And I said, what's the problem? She said, I can't get pregnant. And I started to ask her the ordinary questions we always ask when somebody says they can't get pregnant, like, when was your last menstrual period, how regular are your periods, and everything. And she wouldn't answer. And tears were streaming down her face. And I said, Mary, we can deal with this problem, but you need to answer some of the questions. But you need to tell me why you're so upset. And she said, I can't get pregnant, and it's all my fault. And I went, no, a third of the time it's the male's fault, and a third of the time it's the male and female's fault together. And I still wasn't cluing into her level of distress. So she looked at me, and she actually started to sob. And she said, you don't understand. I can't get pregnant, and it's my fault. Don't you understand? It's my fault. Like, Mary is a bright young woman. She actually teaches in one of the schools in South Halton. And she's not a really emotional type. So I looked at her, and all of a sudden my stomach dropped. And I went out on a limb, and I said to her, when did you have your abortion? She looked at me, and she was flabbergasted. She said, how did you know? I only told my sister. And I didn't bother answering the question because it was a rhetorical question. I said, when did you have your abortion? She said, I had it at first year university. I was so upset when I found out that I was pregnant. I didn't know what to do. So I went over to Morgenthaler's clinic, and I had the abortion. My husband doesn't even know about it, but I know that's why I can't get pregnant. I said, how do you know that's why you can't get pregnant? She said, well, a few weeks later, I was still not feeling well. Actually, I thought I was still pregnant, and it was about 3 weeks after I had the abortion. And I went into the emerge at TGH, and they told me that I had PID, and they told me it was because I had the abortion. And they told me then and there that I had a 50% chance of never being able to conceive. And that's the human face of the problem. But is it limited to just infertility and subfertility? No. One of the things which the European studies have shown over the last 10 years is that there's a dramatic increase in the rate of premature delivery with induced abortions, following induced abortions. There's many reasons for this. Part of it's infection, and part of it is the damage which is done to the lining of the uterus and to the muscle which is at which is in the cervix. And so there's women who get pregnant and deliver their babies early. Now, 10% of all babies are delivered early. But induced abortion actually skews that prematurity rate downward to 25 to 27 weeks gestation. And so the babies which are born prematurely after induced abortions are very small, 500 to 750 grams. And they get problems because they can't breathe properly, so they have RDS. Most of them need intubation and be put on a respirator. And the stress of this often causes bleeds in their brain and problems with infection. So they end up with considerable problems following it. They end up with chronic lung disease, and the babies who bleed into their brains end up with handicaps. They're blind, they're deaf, they have learning disabilities, they have developmental delays, and 7% of that group of surviving infants have cerebral palsy. 25% of them die. These babies who are developmentally delayed cause a lot of stress and hardship on their families. 3/4 of the marriages of babies who are handicapped and have cerebral palsy end up breaking up. So not only do the babies suffer, the families suffer, and the siblings suffer as well. But is that the only thing? No, there's a shroud of secrecy around two other issues which are related to abortion. And one I'm going to deal with very briefly, and that's called the ABC connection, and that's called the incidence, and that's the breast cancer-induced abortion risk. So the abortion breast cancer risk. Now, there's been a lot of stuff in the literature, and in 2007, the National Cancer Research Institute of the United States issued a document saying that there is no evidence that induced abortion causes an increase in breast cancer. And there's a number of publications out which say the same thing. Why can they say that and I stand up here and tell you that there's a 5% increased risk of having breast cancer following induced abortions? Who's right and who's wrong? And I'm going to tell you that I'm right, okay? And I'm going to tell you that the National Cancer Institute, when they did their studies and when they had their workshop, they invited only pro-choice gynecologists to attend their workshop. They only considered the data from America. They didn't look at the data from Australia and New Zealand. They didn't look at the data from Europe. They didn't look at the data from China. And it's very clear, if you do the studies properly and you don't do fancy things like delete 60,000 women off your data list, which is what one of the major studies did, so that they could actually skew the data the way they wanted it to read, that induced abortion, because of the changes from the hormones and the rapid drop in hormones following an induced abortion, actually causes an increase in breast cancer. If you happen to be under the age of 19, it doubles your risk. If you happen to be under the age of 19 when you have your induced abortion and you have a family history of breast cancer, you increase your risk by 310%. That's a lot. What's the risk of breast cancer these days in Canada? When I originally started doing this talk, it was 1 in 12 women had a lifetime risk of breast cancer. Right now, the lifetime risk of breast cancer is 1 in 10. So you women, look around. 1 woman out of every 2 tables is going to have breast cancer sometime in their lifetime. 5% of that's related directly to induced abortions. The other thing which is surrounded by a shroud of secrecy are the mental health issues that follow induced abortions. And when I think of this, I don't have to think back too far to find examples in my practice. Last week, in addition to the Kate who came in, I also had one of my other young patients come in. I'll call her Sherry for matters of privacy and everything else like that. Sherry's had some ongoing issues in her young life, dealing with self-confidence and self-esteem. And she had been in psychotherapy with one of the leading psychologists out in our area, and she had been doing very well last spring. She had completed her first year of university, and I thought she was doing great. She came in and she was sitting in front of me last week, and she was so sad. And I said, Sherry, what's the problem? She said, well, you know what? Life really isn't worth living. And I said, what's your problem? She said, I am so stupid. I make such stupid mistakes. I really don't know how to order my life, and I don't know what to do. And I am really stupid. I said, well, you know, we all make mistakes sooner or later in life. What's the problem? She said, well, you know, my period's late. I said, oh, you're pregnant? She said, yeah, I think so. And I said, what do you want to do about it? She said, well, I'm going to have an abortion, just like I had an abortion in May. And I went, Sherry? She said, well, you know what? I won't be any good as a mother because I killed my first baby. She said, I can't have a baby. I can't ever be a mother. And what had happened is that her whole self-esteem and the way she thought about herself had been really affected by her abortion. And she'd become depressed, and she'd really lost contact with who she was. And it transpired that after she'd had the abortion in May, she'd gone through 4 boyfriends over the course of the summer, and she hadn't used any birth control. And she'd gotten into drugs, and she'd been drinking too much. And this past time, where she thought she'd got pregnant, she again got drunk, and she'd ended up having sex with somebody she didn't even know. This sort of promiscuous relationship and use of drugs and alcohol to dull the senses after abortion is really common. And in fact, in the States, the self-report rate of mental health problems after abortion is about 17%. That means that 83% of women fly through having their abortions without any mental problems at all. But that 17% is a real problem, because we know from statistics that the increase in risk of suicidal ideation and suicide is over 200% in women who've had induced abortions. And that this increase in risk for suicide isn't time limited. It lasts for a lifetime. And if any of you have had a family member or know a friend who has tried to commit suicide, or know somebody whose child who's actually committed suicide, you will know that it's a grievous and tragic event. So, where are we at with all of this? We know that induced abortions have major and significant effects. We know that it affects the women who we know in our community, and that the women who suffer a loss of control, guilt and shame from an abortion are really caught in a conundrum where they don't know what to do and don't know how to deal with it. And I want to close with just a reflection about a conversation which I had a couple weeks ago in Nairobi. Now, Nairobi is the capital of Kenya, and right now in Kenya they have a famine because they haven't had any rain for 3 years, and there's been civil unrest. Actually, there's been civil unrest all the way through the eastern horn of Africa, Somalia, Sudan, Uganda, and Kenya. And so the crops have been burnt and the crops haven't been planted, the rains haven't come, and 80% of the population is hungry and 20% of the population is now starving. There's been a mass influx of people into Nairobi. The slums, which 2 years ago were said to be the largest in the entire world, are now even larger. And the 10, 15, 20 people are crowded in 8x8 houses without running water, without any water frequently, without electricity, without sanitation, without garbage pickup. The missionaries of charity who I was working with 2 weeks ago, they get up at 4:30 in the morning and they go out and they pull babies out of the garbage heaps and out of the ditches and bring them home to their orphanages. Because even though There are so many people. Abortion is really expensive, despite Kenya's agreement to pay for abortions for any woman over the age of 10. So we got into a conversation at Tangaza College, which is a theological school for the Catholic University of East Africa, and somebody was saying that given the suffering which is going on in Nairobi and in the slums, it's a good thing that the Kenyan government is now paying for abortions. And they talked about the fact that it was a good thing that women would be able to access abortion. And again, I found my voice and I spoke up and I said, no. Abortion is not right. It's not right for the baby. It's not right for the mother. And it's not right for our society. So what are we going to do about it? And I think ultimately what we need to do, each one of us, is that we need to speak up and we need to say the truth and speak the truth. Abortion is neither a right and nor is it right. In fact, it's a difficult, poor second choice for a woman who's facing an unplanned pregnancy. Thank you.